Welcome once again. I hope we can get started. We are already 6 minutes delayed, so let us catch up while we present these cases and let's have some time for discussion, hopefully. I'm happy to announce the co-chairpersons, Dr. Saurabh Jain, Dr. Eric Bothan, and Dr. Shubhangi Bhavi. Welcome, everyone. Without much delay, let's have the first talk by Dr. Digvijay Singh on strategies for management of third nerve palsy.
Okay, do we have the pointer here? Okay. Big thanks to the AIOS Scientific Committee for having me as a part of this session. Just project it on the system. So I'm going to talk to you about, we're probably going to start with one of the toughest things that we as strabismologists have to manage, which is the third nerve palsy. And yeah, there it is, which is the third nerve palsy. And I'm going to talk about a few management strategies that we use in these cases, and essentially the challenges. So we all know that in third nerve palsies, you'll have an exotropia, you'll have an eye in a down and out position, the pupils may be involved, there would be ptosis, so ptosis also needs to be managed alongside with this, some mild proptosis, and you could have associated cranial nerve palsies, which just kind of makes it more complicated or makes the system more difficult. This is what a complete third nerve palsy would look like, a ptosis, a down and out eye, you can see the pupil getting involved here, and the issue with these cases is because of the involvement of multiple muscles, we have a challenge as to how to tackle them. In nuclear third nerve palsies, you can have ptosis bilaterally. The other eye, contralateral superior rectus, may also be involved. The pupil may sometimes be spared. So within the third nerve palsy also, you've got individual cases that you have to look at. You could have a partial third nerve palsy where you've got recovery of some of the muscles or non-involvement of some of the muscles. And then you've got aberrant regeneration, as you can see in the pictures below, where on adduction you can see that the ptosis is getting corrected in the eye. So these again are situations which are unique and which need to be tackled with. As I said, it's primarily multiple muscles getting involved, so you don't really have that much scope to operate or look at. There is ptosis, there is diplopia, and this can be tackled to some extent non-surgically, but in most of these cases, if there is no recovery or partial recovery, you would require a surgical intervention to correct it. In terms of medical therapy, you've got prisms for small deviations. You can use segmental occluders or occluders to control the diplopia. And of course, one good part sometimes is that the ptosis prevents the diplopia from happening. So your patient actually may not be that bothered as compared to other nerve palsies, at least in the beginning, till some recovery starts to happen. Chemodenervation, we all heard very well from Dr. Saurabh now, so we can use botulinum toxin. Here we're going to use it on the lateral rectus muscle, which is the antagonist of the medial rectus that we are treating. So you could do it in just the fashion that you had described it earlier. Surgical therapy essentially would be done after at least 6 to 8 months, once it has stabilized, the deviation has stabilized, and the purpose or the aim of it is to actually get diplopia-free area in the primary and down gaze, and also correction of the ptosis to some extent. And it is challenging, as I've said, because of the involvement of multiple muscles. And the various options that we have is to weaken the antagonist muscles, as we can see here is the lateral rectus that's there, or the superior oblique, or strengthening the agonist muscles or the paralyzed muscles here, or you have to do a contralateral eye surgery as well, sometimes in aberrant regeneration. I'll show a couple of cases of that as I go along. And you can do transposition procedures as well. You can transpose the lateral rectus towards the medial rectus, the superior rectus, and again, these are on a case-to-case basis. And I'll come to some of these indications just down the talk. In incomplete third nerve paralysis, you can use, depending whether it's in what muscles are involved, whether it's a superior division or an inferior division, you can choose your surgery. So this is just a picture there to talk about various options that we have. But in essence, the basic principle remains the same. We want to weaken the antagonist and strengthen the yoke muscles that are there. And specifically in aberrant regeneration, we often have to touch the other eye surgery as well. And in complete third nerve palsies, after we've all done all this, we also have to do a ptosis management. And here we need to look at the LPS action, we need to look at the Bell's reflex, and only then we can go ahead and lift the lids, which could be done by a sling or a resection or a plication based on how much ptosis there is. So, and of course, along with this, you need to manage other aspects as well, any other nerve palsies, dryness, dry eyes that have happened, the pupils, you need to give miotics, you need to give near-ad. So all those also come part of the third nerve palsy. So it is in fact a more complicated affair, as we can see. So let's look at this, a case of partial or incomplete third nerve palsy. You can see that there is an exotropia, and here we can get away with the resection procedure. And remember, we want to do a supramaximal recession now of the lateral rectus, because we want to weaken it substantially, and not just what we see in the comitant squints that we so far are treating. Now, in cases of aberrant regeneration, as you can see in the picture above, where there is an adduction and the ptosis improvement, you need to operate the contralateral eye, and that's a discussion you need to have with your patient. And you can see here we've done the left eye lateral rectus recession, and that has actually corrected the ptosis along with correcting the exotropia. And here's another case with a similar kind of an outcome. Again, these are cases you need to discuss with your patient, and you need to explain to them why you want to do the normal eye, which is not usually the eye that we are that is actually affected. So as far as he's concerned, you're doing something which is different. You can also correct the vertical deviations that may happen with a shift of the horizontal recti muscles as you're doing a resection in them, as you can see in this case, and that also corrects the vertical deviation. In complete third nerve palsies, such as the one here on the left, you can see full ptosis, eye in down and out position, no movement whatsoever. You have an option of anchoring the globe to the medial wall, or the periosteum in the medial wall as well, along with the recession of the lateral rectus, and you can get good alignment in primary, but there will be no ocular movements after that. Here's another case, but not necessarily in all cases does the globe anchor work very well, as you can see here, that there is a residua that is remaining. Another option that we have is to do a lateral rectus periosteal anchoring, and that's actually a severe form of weakening of the lateral rectus that is there, and you can see that we're getting a good correction in this case of right third nerve palsy after doing a lateral rectus periosteal anchoring and strengthening of the medial rectus. But as again in this case you can see, there are times if you have not done the anchor very well, or some part of the lateral rectus is still touching the globe, or you've not been able to separate it or compartmentalize it from the globe, you could actually end up with an undercorrection. But these are expectations that you have to explain to the patient and the family beforehand. And that's also one of the important conclusions that we'll have at the end of this talk. Here is a case where you're going to be seeing that there is a very large angle exotropia because of the third nerve palsy, and we are seeing that we've done a transposition of the full tendon lateral rectus as well. And though here you could see the result was less, but if you come to this case here, where we've actually done a split tendon transplantation with a posterior fixation suture at the back, we get a much better result in the long term, and you can see such a large deviation getting corrected. So now transposition procedures are also gaining popularity, and this is something we're doing more and more, as we know that lateral rectus is one of the only functioning muscles left after in cases of complete third nerve palsy. This is a lid-sparing third nerve palsy, and you can see again we've done a tendon transposition, and you can choose to do a superior or an inferior route for a full tendon, or you can do a split tendon transposition of the lateral rectus. And so this is the idea of this talk, is just to sensitize you with various management strategies that we have. And as was discussed with the previous speaker, when you don't have one good strategy, then you have many strategies that come about in play. So this is again a case of third nerve palsy. Now let's look at the conclusions. So one, we have to look at whether it's a complete or incomplete third nerve palsy. We have to see if there's any aberrant regeneration. We have to see if the patient is willing to operate the contralateral eye in those cases. But most importantly, we have to establish the expectations. We have to let them know that these are cases where there will be undercorrections, sometimes rarely overcorrections as well, and that the ocular movement does not come fully, as you had seen in all those 9 cases, despite a full surgery. And it's only after that that you plan your surgery on an individualized manner and you proceed with that. And do remember that you also need to manage the pupil, you need to manage their near vision, you need to manage the ptosis, and that too can be done with the support of your oculoplasty colleagues or yourself. And in those cases, make sure that there is a decent Bell's reflex and some amount, and the eye does not end up with a dry eye or an exposure afterwards. Thank you.
Thank you, Digvijay, for the wonderful overview of third nerve palsy. Probably we'll have questions after maybe 2 talks rather than at the end. We will call upon Dr. Swati Fulgile to talk on options for management of 6th nerve palsy, from third to 6th nerve palsy. as from the talk, you know that third nerve palsy, there is no specific treatment. There are multiple surgeries coming because no one surgery works in third nerve palsy. Probably you need to customize. To that list, I think probably superior oblique anterior transposition in some of the cases works well, especially when there is exotropia with hypertropia, very large one. Over to you, Dr. Swati.
Good morning, everyone, and welcome to this session of strabismus, which is a complex strabismus, or having dealt with the simpler form of the strabismus. We are now dealing with the paralytic and restrictive strabismus. I'm Dr. Swati Fulchile from RP Center, AIMS, and I'll be talking about management of sixth nerve palsy here. So as we all know, sixth nerve palsy presents as limitation of abduction, and there will be esotropia with the face turned towards the affected side. Its major differential include ESO-DRS and infantile esotropias with cross-fixation. So they are often confused as whether this is a DRS case or a sixth nerve palsy case. But if we look at the amount of deviation in the primary gaze, that will give us some clue whether it's a restrictive strabismus or a paralytic strabismus. In restrictive, generally the amount of deviation is much less as compared to a paralytic strabismus. As far as infantile esotropia is concerned, it's always important to check for the duction. So not just version, ductions have to be checked. Etiology include from all range of causes like microvascular occlusion, trauma, neoplasm, inflammation, or congenital. So this is a case where there was a risk factor of diabetes and patient had isolated sixth nerve palsy. Very simple case to diagnose, no problem there, and will have a good recovery. We all know that. This is another case, very interesting case. So it can be a manifestation of something very sinister. So 27-year-old female presented with just an inability to move left eye outwards for 10 days with a history of headache and fever. So on neuroimaging, this is what we get, an extensive inflammation involving all the sinuses of the brain. So sixth nerve palsy, one should never take it as lightly because it may be a manifestation of something very serious in the brain. Next, it could be a false localization sign in cases of raised ICT. So how do you neuroimage these patients? So depending on the age of the patient, the risk factors there, the involvement of other cranial nerves, other neurological features, you have to image the patients. But if patient is old enough and you know that's probably a microvascular occlusion, you may choose not to image. So coming to the indication for therapy, as already described by Dr. Digvijay, so it's the diplopia in the primary gaze, which is a problem, and a constant anomalous head posture you need to correct. So therapy can be non-surgical and surgical, as it has been discussed earlier also. We can also give Botox, as talked by Dr. Saurabh Jain, very nicely showing some cases. So the same thing can be given in the paralytic cases also. So here, this is a case of sixth nerve palsy, where you can see that the left eye had poor abduction, and after giving the Botox, the improvement, you can see the patient is very well aligned there. So if your Botox fails, what are your options? So there is whole range of surgeries you can do, as contrary to the third nerve, where you have very limited surgeries which you can do. Sixth nerve palsy has, because other muscles are very well functioning, you have whole range of surgeries there which you can do. So depending on the recovery of abduction, depending on the amount of deviation, you may choose to do a recession resection procedure or a transposition procedure. So the algorithm says that if you have a good recovery of abduction, you may choose to do a recession resection. If you have limited recovery of abduction there, depending again on the status of the fibrosis of medial rectus, you have to do whether you want to recess the medial rectus or not, along with the transposition surgeries. So here is a case where you can see that there is a left eye esotropia over there with abduction, no abduction limitation. It's recovered sixth nerve palsy. So doing a simple recession resection procedure, but it has to be a supramaximal dose. As converse to the conventional surgeries, where we limit our doses to maximal dose of 6 and 9 for MR and LR, we need to do a supramaximal recession resection procedure in these cases. Here is another case where it's a post-traumatic sixth nerve palsy, and you can see that the abduction in the right eye is significantly deficit there. But the FDT for MR is negative. So what's your choice? So in such cases, your whole array of transposition surgeries, you may choose to do a double muscle, vertical muscle transposition, or you may choose to do a single vertical muscle transposition, you may choose to do a full tendon transposition or a partial tendon transposition depending on your need to do the MR recession and the amount of deviation. So this case, we chose to do a full tendon vertical recti transposition, and you can see that the patient recovered a good abduction there as well as alignment also. So this is another case where you have post-traumatic 6th nerve palsy. Here also you can see that there is a severe abduction deficit there, and the FDT for medial rectus is tight. So what do you do now? If you do same procedure, if you do a full rectus transposition, you still have a risk of anterior segment ischium because you need to recess the medial rectus. So you have a choice here to do a partial tendon transplantation, or you can do a single muscle transplantation. So in this case, we did half-width vertical recti transposition to lateral rectus along with the MR recession depending on the tightness. You can modify or you can augment your transposition surgeries with the help of posterior fixation suture, again depending on the amount of deviation and the amount of correction that you need post-operatively. More and more nowadays, the a single muscle transposition surgery is gaining popularity. You may choose to do it with adjustable medial rectus recession, or you may choose to do simply a transposition surgery, again depending on your deviation. So this is a case where we had done SRT, superior rectus transposition with the adjustable MR, because the deviation was quite significant there. It was a large deviation with a large abduction deficit. The post-op patient was relatively aligned with good abduction recovery. Now this was a very interesting case. You can see here that this child has esotropia in the right eye with the abduction limitation, and also has bilateral inferior oblique overactions. So if we do, we have to operate for the inferior obliques here because there is a significant V pattern, but at the same time we have our own concern that if you do superior rectus transposition, it will not only worsen the V pattern in the up gaze, but will also limit the elevation because both of the elevators will be involved. So the fundus here showed extorsion, so, confirming the inferior oblique overaction. FDT for MR is free, so what we chose to do is to do a right eye MR recession with bilateral inferior oblique recessions with inferior rectus transposition here. So this is the post-op results with good alignment and good abduction recovery with the collapse of V pattern. Modified Nishida is also an option in such cases where you can do it with and without MR recession depending on the amount of deviation. So in this study was published from our center regarding the adjustable MR recession with Nishida procedure, and a good correction was achieved. So this is a review article which has collaborated all the studies and given us the results. So we have seen that the full tendon double vertical rectus transposition is as good as single rectus vertical rectus transposition with or without augmentation suture. So to conclude, it's a commonly affected cranial nerve. One needs to rule out the intracranial lesions depending on the presentation. RNR surgery can be done if there is a good action or power in lateral rectus. VRT single or double depending on your choice and comfort you can do. Thank you.
Thank you, Dr.
Any questions?
Swati. Yes. Can we ask one question? Okay. So
Thank you.
I think we'll have the discussion later because we are running behind the time. I request Dr. Rohit Saxena to present his talk on DRS customized approach. Dr. Rohit Saxena is from RP Center, Professor of Ophthalmology.
Thank you, AIOS, for the opportunity, and it's an absolute pleasure to be here. We can start the moment the slides come on. They are there. Thank you. So I'll be talking about Duane's retraction syndrome. And next slide till the time I get charge over here. Yeah. Great. So the essential thing for management, the most important thing is to understand the pathophysiology. And just a quick brief about it, Duane's is extremely interesting. Its presentation can be very, very unique. Of course, it's now part of a comprehensive overall congenital cranial disinnervation syndromes, and we get a lot of different kind of disinnervations, and this is one of the most common disinnervation. The basic pathology is nil or subnormal innervation to the lateral rectus from the sixth nerve. The lateral rectus gets abnormal innervation from the third nerve, the medial rectus subnucleus essentially. Therefore, we also need to remember in our management that there is some amount of varying degree of subnormal medial rectus innervation also. So even though it's an ESO-Duane's that you start off with, the medial rectus is still underperforming because the number of fibers that are coming to the medial rectus would definitely be a little less than what it normally would be, because some of them go to the lateral rectus. And then overall, the different presentations are because of the secondary muscle changes. So you may have theoretically a fair amount of similar pathophysiology, but we'll see the wide variability in the presentations that we're going to get. And each case will therefore require a unique approach. We need to remember that our aim of surgery can be to reduce the deviation in primary gaze, to eliminate the abnormal head posture that the patient may have, the disfiguring retraction that may be there with or without the presence of shoots. So we'll just run through a few set of cases. This is an ESO-Duane's. You can see the narrowing with the palpebral fissure and the abduction deficit. Good stereopsis, so an ESO-Duane's. Now, this is something that we can overall remember what we're doing. Options are increasing with time as new and new surgical techniques are being discussed. But if you have a small esotropia to start with, you can do a small medial rectus recession, or you can do a vertical rectus, an SRT, IRT, or a split vertical recti transpositions. If the angle is more, you may have to do both. You can do a asymmetric bimedial recessions, or you may do a small medial rectus recession with a vertical rectus transposition. Co-contractions will require that you have to tackle the lateral rectus also, because that is the source of the co-contractions or abnormal firing of the lateral rectus. And of course, bilateral, you may have to kind of do both the eyes and manage each eye individually. So in this child, we did the involved eye, small amount of medial rectus recession, good primary gaze alignment, but you can see that there is an adduction deficit. In a comitant squint, had you done 5 mm of medial rectus recession, you wouldn't have seen any adduction deficit. But in a Duane's, you are very likely to see, it may get a little better with time, but the adduction deficit is there because, as I mentioned in the beginning, the MR is still a theoretically paralyzed muscle, and you've weakened a paralyzed muscle. So it's important. That's why we generally have very minimal or very small amount of recessions we do for the medial rectus because of the adduction deficit you're going to see. So do not do large medial rectus recessions. It does result in adduction limitation. If there is a significant amount of retraction that you see, if you do just the medial rectus recession, you may in fact have a synergistic divergence in the post-op, which will be very, very bad, or the splits, and therefore you may have to do the lateral rectus also in a case like that. We'll see. So another child with ESO-Duane's, you can see the amount of deviation was greater. In this, we did a very small amount of medial rectus recession. I generally would do the magnitude of medial rectus recession depending upon the force duction test. So my aim is just enough MR recession to free the force duction test, and along with that, we did a superior rectus transposition. I do not add a posterior fixation suture to the transpositions SRT or IRT, which I do in Duane's, although I add a posterior fixation in a sixth nerve palsy. So essentially, we still get very, very good results if you do a vertical rectus transposition along with a small medial rectus recession. You may get a small amount of adduction deficit, but it's usually less. So advantages of transposition would be you do get, like you would see in this case, you can see a significant abduction that you can get. So this is an advantage of doing a transposition procedure. Less amount of medial rectus recession is required. Possibly you may have less amount of post-operative drift or recurrence of the ESO, but do not plan SRTs or vertical transposition if there is significant retraction. In fact, at that point, you may have to do a lateral rectus recession. We've done SRT with adjustable medial rectus recessions versus both muscle transpositions, vertical rectus transpositions. The results were comparable, and therefore you could choose either. In lateral rectus, resections have been described. Small amount of resections, they say, is possible, especially if there is not significant retraction to go off with. But remember, even if you do, I don't have any experience in that, but it has been reported, so I'm just mentioning it here. But do a very, very small amount if there is a modest amount of esotropia you want to correct for. But definitely not if there is co-contraction, because it's going to worsen the co-contraction. This was the case of bilateral esodwans, and in this, we did a little larger amount of medial rectus recessions to start with, because of the fact that the angle was very large, so modestly greater than I would have normally done. But again, it's important to operate each eye based on the amount of angle that is present when the patient is fixing with the other eye. So that's an amount of deviation you have to check for. This was a child with esodwans, small ankle eso, but a retraction. So in this case, we had to do differential recession of both the medial and the lateral rectus. So the medial rectus was recessed to correct for the esotropia, and the lateral rectus was recessed to correct or to manage the retraction. And that is essential if you are doing, if there is retraction in a case with esodwans. Otherwise, as I mentioned, you're going to land up with an exotropia in primary gaze or a synergistic divergence. We'll quickly go on to exodwans, and this was a very severe exodwans. You can see the severe retraction that is there. In attempted adduction, the eye is almost disappearing in the lid. So shoots and retraction often frequently accompany exodwans because the lateral rectus is also very tight. So again, options available would be a large lateral rectus recession, a Y-split if there are shoots, and of course, a major option can be you can do a periosteal fixation of the lateral rectus, which theoretically is like an infinite recession of the lateral rectus. So you've done a very, very large recession. So in this case, we did the lateral rectus periosteal fixation. You can see that there was a modest amount of abduction, which is lost, but there is very good alignment, and the retraction and the shoots has completely disappeared. So you get a good effect if you do periosteal fixation in cases like this. Again, another patient in which we did periosteal fixation, but in this we added a vertical rectus transposition. The essential reason why we did that in this case was that there was a fair amount of abduction in this patient. We have seen, after doing a lot of cases of periosteal fixation in Dwans, we realized that about a third of them would go on to develop an esotropia over time, early or late. And among the reasons were that there was some amount of normal lateral rectus function seen by abduction in the preoperative period. So these patients have a risk of going into a consecutive ESO, and for them, either as the same intraop in the first stage or a subsequent stage, you may require to do something for the consecutive ESO that can develop. So essentially, if there is abduction present, you may have to add a vertical rectus transposition in these patients. Exodwans with severe shoots, you can see the severe amount of globe retraction. Remember, sometimes the retraction may be present in primary gaze itself, and that may be the cause for the hyper or hypotropia, and you may not require a vertical muscle transposition surgery in that case. So first, release the lateral rectus, make sure that the FDT is free, you've removed the co-contraction, and then see if there is any residual vertical deviations. Sometimes that may be also due to the inferior oblique overactions that may be there. Finally, orthodwans, you would not touch unless there is retraction. And if there is retraction in orthodwans, then you will have to do again differential recession of the lateral rectus and the medial rectus so that there is no consecutive deviation in the post-op period. So you only do surgery if there is significant retraction in orthodwans, and that is the only indication for intervention. So take-home message. You need to have very clear indications. You need to discuss with the patient that normal ductions and versions cannot be achieved. So the patient must be aware that this is going to remain post-op. And of course, essentially, we aim at increasing the area of primary of binocular single vision, and a lot of things remain to be desired. So thank you very much for the opportunity.
Thanks, Dr. Rohit. It's like in each Duan's case, we have to put on our thinking cap, and it helps. And with this, I call Dr. Manjula Jaikumar for a talk on DVD syndrome, a way out. Is there a way out, Manjula? I don't know.
Persistent disorder. So is it really a way out with DVD syndrome? the end of the talk, we will be able to get the answer to this question. DVD is actually a disorder with a lot of paradoxes. It's a marker of early binocular vision impairment, but it itself presents much later at the age of 1 or more. It can be associated with a horizontal or vertical deviation, but DVD is more cosmetically disfiguring than even the original deviation. So what are the clinical features? It could be manifest or latent. It's a complex. The eye elevates, abducts, and extorts. And you have to look for the intorsion sometimes in the fixing eye. There's no corresponding hypertropia of the fellow eye, which means it doesn't obey the Hering's law. The eye with DVD can be associated either with a good or poor vision. You have to examine carefully for the presence of a latent or manifest latent nystagmus in the eye. There could be a head tilt sometimes, usually on the eye towards the DVD, and most probably it's a bilateral disorder, but with an asymmetric presentation. So you need to unmask this asymmetric presentation. So how do you measure the DVD? It's not straightforward because there's no Hering's law observed, and you can't do a straightforward PBCT. So what you go and do is a prism undercover test. Let's watch this video. So you can see that there is clearly a DVD in the left eye. So you put prisms of strength to prevent the downdrift. So left eye, there is a DVD. I'm putting approximately 12 prisms, base down prism, in front of the left eye. That's not playing. Oh, yeah. So there is, you keep putting the prisms until there is no downdrift. Now you're seeing the DVD in the right eye. Neutralize. So you've unmasked the DVD in the other eye. So you ask your assistant, oh, it has to play a little faster. Okay. Now this is around 10 prisms. Now all that you're seeing is a small flick exo. So you neutralize the exo and you get the DVD, 12 in the left and 10 in the right. This is how you neutralize DVDs and you will unmask. So what if the vision is not good? If the vision is not good, then you have to use the Hirschberg or the inferior scleral show. You match that. Okay, this is an eye with poor vision. So you use prisms to match. See, now the scleral show is matched in both eyes. So this amount of measurement is very important because that will give you as to how much of correction you will go about. So what are the differentials which add to the confusions? DVD is fairly a straightforward diagnosis, but sometimes skew deviations and primary inferior oblique overactions can be the confusions. In primary inferior oblique overaction, you get a V pattern and a corresponding hypertropia of the abducting eye. Skew, the deviation is little concomitant, and you have torsions of the fundus towards the hypertropic eye. So these are the differentials. And when do you interfere? When it is a cosmetic blemish. And when is it a cosmetic blemish? When you have a large DVD, spontaneous DVD, frequency is more often frequent, and there is an anomalous head posture. So you grade the deviation, measure the deviation, and then go about the surgical correction. Sadly, DVD has no medical management. It's always surgical. And the first thing that you look forward is there an inferior oblique overaction? Suppose you have a DVD with inferior oblique overaction, as you see in this child, then you do an inferior oblique anterior transposition. The solution is simple. You do AIOC2024 in both eyes, but you can make it asymmetric if the inferior oblique overaction is asymmetric between the two eyes. And the results are beautiful and also very long-standing. And if there is no inferior oblique overaction, then you have to address either the superior rectus or inferior rectus. In this case, it's a non-seeing eye. She has very poor vision in the right eye, so I have taken up unilateral surgery. This is the only condition when you would operate DVD unilaterally, when the vision is very poor. So this eye, I've done a large unilateral inferior rectus recession. So when you do unilateral recession, your surgical dosage will be slightly lesser than bilateral surgeries. So this is the table which I broadly follow. So you see the dosage for each and every measurement of deviation, unilateral versus bilateral, the surgical dosage is about 1 to 2 millimeters less. So this is how you titrate. So essentially, you will do a bilateral surgery, unilateral only when it is a densely amblyopic eye or an eye with poor vision. The other surgery which you can do equally efficiently is your inferior rectus plication. So IR plication, you can see that this boy has left eye a large manifest. There is a DVD in the right eye too. I have done IR plication in both eyes. Of course, the eye with the manifest DVD, I did a larger plication when compared to the eye with the latent DVD. So asymmetric surgeries, but bilateral surgeries are the surgery of choice. This is a very interesting case. This child had DVD in one eye. Both are components of the same dissociated strabismus complex, a DHD in the other eye. So what have I done? I've done an IR plication in the right eye, and I have done a large LR recession in the left eye. You can also do a smaller recession with a fade-in, but I chose to do a larger recession. So the results are very beautiful. As you can see, there is no DVD in the right eye. There is no DHD in the left eye. So what are the take-home messages? There is no medical management for DVD. Operate it if there is a cosmetic blemish. Don't operate on cases where there is a small latent DVD. If DVD is associated with inferior oblique overaction, there will be no corresponding hypertrophy of the other eye. In fact, you may have a hypertropia of the other eye too. This differentiates it from primary inferior oblique overaction. DVD with inferior oblique overaction, your surgery of choice will be IO80. Perform always bilateral IO80s. It could be asymmetric if there is an asymmetric overactions. Do not perform inferior oblique over anterior transposition if there is significant superior oblique overaction. If DVD is associated with superior rectus overaction, go ahead with bilateral superior rectus recessions, do asymmetric surgeries, do unilateral surgery only if the eye is densely amblyopic. Do not do superior rectus recession and inferior rectus plication at the same setting. If you're planning to do that, do it as a staged procedure because you can anticipate your results better if done so. If superior rectus recession is combined with an IO80, do a very, very small superior rectus recession. So these are the take-home messages. Yes, my answer is an emphatic yes. DVD syndrome definitely has a way out. Thank you very much for your patient hearing.
Thank you very much, Dr. Jayakumar, for such a fantastic talk. So we're running on time, so I think we'll go to the next speaker. Very happy to invite to the stage again Dr. Pazavandi from Singapore National Eye Center to talk about thyroid eye disease.
Thank you, Saurabh. And could we have the next set of slides, please? Yes, I'm going to be talking on changing trends in the management of thyroid myopathy. So, it's not moving, huh? So we all know that in thyroid myopathy, we have the active phase and the quiescent phase. The active phase is treated with various modalities, steroids, radiation, orbital decompression, immunosuppression. At the end of the whole thing, when the patient goes into the quiescent phase, the strabismus often persists. And yes, most cases will need surgery. The strabismus surgery in thyroid myopathy has a very different kind of a thinking and philosophy which we need to use. And you need to be more experienced in trying to deal with these very tight fibrotic restricted muscles. It's more about the feeling to know which muscle is the culprit when you have a bilaterally asymmetrical condition. So it's quite important to do the force duction test preoperatively to determine and identify the restricted muscle. And the best way to be able to get a predictable outcome would be to use adjustable sutures. And in our case, we do intraoperative adjustment. I'm going to share with you an example of a patient who had an esotropia of 50 prism diopters after a bilateral orbital decompression. And we did a bimedial supramaximal recession for this patient. And I'm going to share with you the surgical video now. We do this surgery under topical anesthesia. The anesthetic we use is an amethocane 0.5%. And we are beginning with the patient on the table. We are doing a preoperative cover test. And then I'll show you the steps of the surgery on the video. There are subheadings, but I'm not quite sure if you will be able to see them because of the screen. So here we have the patient moving around and in the desired direction. We don't need traction sutures because the patient is awake. We use a little pledget to prevent the glare from the operating light. We are hooking the medial rectus muscle, which was tight, so we are using 2 double hooks. Now we've replaced it by using a right grooved hook. We do a double central security knot, and we take locking bites at the poles of the suture, which are full thickness locking bites. The suture used is 6-0 vicryl double arm. And we disinsert the muscle. We are using an Abley scissor because of the tight fibrotic muscle. We put it on a slip knot at the desired recession point. In this case, we put it, I think, at 7.5 or 8. And here is a cover test with both eyes medial rectus on slip knots. And do remember that when you do the surgery, the closing, we would like to recess the conjunctiva, which is also tight and fibrotic, in order to augment the effect of your muscle recession. Okay, so that's a good result. But now we are going to share with you a surgery where we had a bad result. This was a patient who had a right hypotropia. We did a right eye inferior rectus recession under topical anesthesia with the vicryl suture. 8 weeks postoperatively, the right hypertropia gets converted into a right hypertropia with limited depression. Okay, we got a very bad overcorrection. So since then, over the years, we have moved to now using non-absorbable suture. There's been a lot of publications wherein absorbable sutures have caused an overcorrection. So we now use a 6-0 mercilin, which has caused more stable results. This is not without its own problems. It does cause some amount of suture granuloma at times, and it can protrude through, but it's easy. You can just snip it off on a slit lamp several weeks or months once your alignment is stable. So progressive overcorrection after inferior rectus recession, is it a surprise? Not quite. We knew it's been happening because of the high tension of the restrictive muscle. Maybe the loss of arc of contact, a tight ipsilateral superior rectus, there's proptosis, there's Bell's phenomenon going on, use of absorbable sutures made it worse, and large recessions was causing this phenomenon. Less surprises and less grief after doing inferior rectus recessions can be by using a non-absorbable suture, limiting the recession, doing adduction-based rather than a deviation-based surgery, think bilateral, and we do intraoperative rather than postoperative adjustables, and always target a slight undercorrection. I'm going to share with you a very desperate case now. 70-year-old lady with a very large right hypotropia, which measures at about triple numbers. It's 130 prism hypotropia, okay, and with totally limited elevation. Fundus photo showing you marked excyclotorsion in the right eye. We did a right eye inferior rectus recession. There's no question about adjusting when you have a triple degree strabismus. Subsequently, the hypotropia went from 100 plus prisms to 70 prisms. Excyclotorsion improved from, as you can see, even in the fundus photos and on measurements. So now we move to the left superior rectus. We recess that also on a non-adjustable suture. And now this is before the superior rectus recession surgery. This is after the left eye superior rectus recession. So we've come a long way. We've come from 130 prism hypotropia. We are now down to a 20 prism hypotropia. Patient, of course, is still not happy because to her, the double is still there. You know, we could be happy, but they are not happy. So what is our next choice? You see here, torsion is improving every time with the subsequent surgeries. So what else do we do now when we are stuck with this small residual, it's not that small, 20 prism hypo, symptomatic diplopia? So we either recess the right inferior rectus, or we want to, we've already done a right inferior rectus recession, we've already done a left superior rectus recession, and there's still a hypotropia. So what else could we consider? So we decided to do a small plication on the right superior rectus. What do we expect? Did we overcorrect? Did we undercorrect? Did we need to adjust? I did this under general anesthesia because this patient was quite anxious, so none of her surgeries could be done under topical. So we lucked out with the small superior rectus plication, and finally we got the patient to be ortho and fusing. So resections, plications in the past were thought to be unusual and not to be done in patients who had restrictive myopathies, because in some ways we were causing more muscle stiffness, maybe creating additional restriction, more inflammation. But it has been now being practiced more and more. We have a lot of publications talking about unilateral recess, resex, and plication. The only two prerequisites we need to look at to have a normal post-duction test and to make sure that there's no significant muscle enlargement of that targeted muscle which you are plicating. And one more lesson learned over here will be that supramaximal recessions may not always be enough. Do stage procedures to avoid an overcorrection, and application just comes to use. It is ciliary sparing, it's reversible, and it's a nice procedure to be done when you have just an endpoint alignment to be achieved. Thank you so much.
Thank you, Sonal, for an excellent talk. So next I'm going to invite Dr. Son from Copenhagen again to talk to us about strabismus surgery after retinal detachment.
Thank you to the audience for letting me have the opportunity to speak again at this wonderful meeting. Right, so I would like to talk about strabismus surgery after vitreoretinal surgery, and our colleagues joke that if the patients have double after vitreoretinal surgery, that's a success. But what do we do when they arrive in our clinic in strabismus clinic? So we need to understand that what the VR surgeons have done is to change the eye's anatomy, and they put these bands around the eye behind the recti muscles, and we need to be prepared to take care of this when we go in and do surgery. And sometimes the band is so tight the eye is completely changed after the surgery. So we face many factors trying to deal with these patients. We have mechanical factors, the muscles are changed, how to do local anesthesia in these cases, and sensory alteration may be a problem as well. So what options do we have? We could occlude the eye, we could use prisms, botulinum toxin, or surgery. And we tried to look at this in our clinic in Copenhagen a few years ago and found 13 patients we wanted to help. And all of them had quite nice vision, and 3 of the patients had torsional diplopia, all kinds of deviations. So we tried to look at how can we help them, and 5 of them were happy with just prisms, but 8 went on to have strabismus surgery performed. And before we do these cases, we try to be prepared. We put all the information on the board in the operation room so we know exactly what to expect when we go in. We do the forced duction test under general anesthesia. We press the eye into the orbit to test the superior obliques, and we leave the eye up in the normal position to test the recti muscles before surgery. We put the numbers on the board so we know exactly how tight was this eye, which direction could it not move. We put that on so we are prepared. We put the plan on the board, and we draw where are we going so everybody in the room knows what the plan is. And this nurse will help us during the surgery. So look at the cases. We did 8 patients. 1 of them had a Faden operation on the other eye, and we removed the buckle or band in 3 patients, and 2 of the patients needed 2 extra surgeries. So in general, the results were good. Torsion resolved to under 2 degrees in all patients, and no of the patients had redetachment, which of course was a fear as well. Sometimes these silicone bands might extrude and we need to take them away, but do we need to remove them when we do the strabismus surgery? Well, there is a group in US and Denmark who looked at historical data to try to answer this question, and they found that in patients with, if you remove buccal in this surgery group, it does not improve the strabismus outcome. Another thing we need to be aware of is you have a buccal for many years, the sclera can be very, very thin. So if you want to work on these patients, you need to see what you're doing, because you can perforate the sclera just with a scleral hook. Silicone oil is another unfriend during these surgeries. They can produce fibrosis and cysts. And adjustable sutures may help you reach the goal and do what you want to do. And the problem after you do the first, if you do this, the eye with the retinal detachment first, the problem is that the eye with the buccal has a lot of scarring and can be very stiff. So the patient may have incompetence and diplopia. And can we improve this? So this is a figure of how the green single island of binocular visual field is where the patient works. Faden sutures may be difficult to perform, and there is a risk of perforation if you do this to the sound eye of the patients, and not all the patients want us to touch the good eye. Another way to solve this is to use a Y-split technique, which does the same as a Faden suture, but is much safer. And this was described by the group in Austria 20 years ago. And the principle is that by splitting the muscle and suturing to the side of the insertion, you actually reduce the torque. So the lever arm is shorter and the torque in that direction of pull is less. So let's see if we have a scleral buccal of the left eye, and this patient looks to the right. The eye does not move so much, so you have they will have double at right gaze. So can we help this in a way? Well, what we can do is to put a Y-split on the sound eye on the lateral rectus, and what happens then is that you slow the lateral rectus down, and you actually keep the patient's, the adductions are balanced at that side. So here's a case where we did this on the sound eye. He had a rutinal plaque in the right eye and had big. So he had a double at up gaze, and we put a Y-split on the good eye and the super rectus and recessed this a little bit as well. And that way you can balance the adductions in up gaze in his case, and his diplopia was gone. So if you do the Y-split only, it will not change anything in primary, but you can have effect in the gaze where the muscle is pulling. And if you combine with the recession, you can add to that in primary. So Y-split is a safe and predictable alternative to Faden sutures in incompetence strabismus, and especially in cases where you want to not harm the sound eye, the good eye, we can do this in the good eye in retinal detachment patients. So in patients who had strabismus surgery, who had VR, retinal detachment surgery done before, diplopia in primary and side gaze and up and down, they can have all kinds of problems. We can treat this with prisms, but if there's, often if there's torsional diplopia, we need to take care of this with surgery. The scarring is a challenge. There's a risk of perforation of the eye, and we always use a microscope to be sure we have the detail we need. And if the silicone buccal is protruding, we remove it, but usually we leave it in place. And in these patients, we want to help them with different strategies, orthoptic surgical treatments, and we may reduce diplopia, correct their abnormal head posture, increase field of single binocular vision by working on the other eye, and also improve psychosocial aspects. And if it's torsional diplopia, we know we need surgery. If it's only horizontal or vertical, they may be happy just with prisms alone. So surgical strategy is to work on the detachment eye first. you may remove the buccal, but it does not necessarily help you. And if incontinence and diplopia, we offer wide split sutures on the sound eye to slow that eye down, to increase the field of single binocular vision. Thank you.
Thank you, John, for that illustrative and very animated talk. Thank you. We will have the questions at the end. Now it's my pleasure to invite our friend from USA, Eric Bothon, who will be talking about superior oblique plication. He's going to share some tricks with old and new friends. Over to you, Eric.
All right. Thank you for the opportunity. As I said here, a new trick with old friends. I think some of the joy of coming to these meetings is we appreciate relationships and learn new things. And I have certainly enjoyed coming to India for some time and appreciated many relationships with friends, and along the way learned new tricks on muscles. And certainly the superior oblique is an old friend. But I think all of us that operate on the superior oblique can understand that it can be tricky or has risks. There are both surgical technique and in choices. We have to be careful in managing the superior oblique. We understand that it is a critical player when it's dysfunctional, either in versional or torsional strabismus. And likewise, when we do approach it, we understand and respect that we can influence vertical and torsional strabismus by operating on the superior oblique. I'm from Minnesota, USA. It's right in the middle of the United States, up in the north, and one of our historical strabismus landmarks in terms of careers was a Dr. Fink. And Dr. Fink is not very well known in strabismus, but back in 1962, he was the one that described the courses of the inferior oblique and the superior oblique with quite vivid detail. And it was after he described that the anterior fibers of the superior oblique probably are the ones that have the biggest torsional impact. 2 years later, there's the superior. 2 years later, Harada Ito said, well, let me use that new understanding and move those. And so the Harada Ito procedure became our first step at intervening for purely a torsional strabismus in a very articulated way, not trying to change horizontals or vertical. And he grabbed the anterior fibers. It was described about 2/3 of it, and he pulled them anteriorly and temporally to correct. So this is a diagram that's been done. You see number C down there, pulling the fibers anteriorly and temporally to create torsion on these fibers. And as you know, we've been doing these for a long time. There are risks at the Harada Ito, but it's been a good friend for us trying to intervene. It oftentimes accomplishes between 5 and 10 degrees of intorsion. That effect typically slides back with time. Your immediate effect is typically stronger, and then it slightly weakens. So sometimes 5 to 7 degrees is what I expect out of a Harada Ito. And then in 1974, the Fels modification. He said, well, why don't we take part of that same tendon, take it and disinsert it, and bring it over to the lateral rectus muscle. And he reattached it about 8 millimeters back, and that became, I'd say, commonly the Fels modification, something we've been doing for many of the last decades, and correcting torsion up to 10 degrees. I will admit in my hands I don't usually get 10 degrees to last out of the Fels modification. Dr. Holmes was a partner I joined 8 years ago at the Mayo Clinic, and he was big into adjustments. I've always done a lot of adjustable post-op procedures, but I didn't do it very often for my superior oblique. I just did the Fels variant. I expected if I needed some good torsion, I'd do it and I'd get 5 to 7 degrees and I'd be happy. But I will admit, having this adjustability became attractive to me. But what I did not like about Dr. Holmes's techniques is you're adjusting way back in this quadrant. It's hard to adjust the superior oblique. It's mucking with tenons. He would put a traction suture to pull the eye down post-op. The patients are uncomfortable, and I was uncomfortable. And so I didn't get into adjusting too many superior obliques, but I realized both on the small end, if you have on the synoptophore someone with a 4-degree extorsion and you want to nail it, because maybe they have history of retinal disease and you really need to get a torsion exact. Or if they have 12 degrees of extorsion, and I know a normal Fels modification may not get it all, I was tempted to try. And so, those of you that know, over the last couple of years, I've tried a modification. Dr. Ameri et al., back in 2009, described plicating the anterior fibers, doing a third, and instead of bringing it forward like Harada Ito, instead of bringing it over by the lateral rectus, they did 2 patients in the operating room where they plicated it and looked in the operating room at the fundus to determine whether they got enough effect. They called it adjustable, but I think what they would do is look in the operating room, look at the torsion. If they needed more, they'd plicate more. I said, all right, I need a new solution. And so I decided we need a more tailorable, adjustable, accessible way safely to adjust for torsion. And so I started plicating with this technique. And you see I still separate a small amount of fibers. It's typically, I don't usually do a third. I think a third is too much and risks more vertical deviation. So I just get that amount. If you're used to working with superior oblique and doing Harada Itos, this might be for you. If you don't usually touch the superior oblique, respect it and maybe get more training before you do. But I tend to find maybe 10, 15, maybe 20% of the tendon. And I will measure a certain amount up. Now we're plicating rectus muscles all the time. It's the same approach here. You march up the tendon a certain amount and you plicate it, and then I reattach it just in front of where it inserts. You can put a hook on it and feel that's where it's inserting, and you reattach it there. And then I bring another one, like a dog leg or a hemi hangback, and I reattach it up front. So this is my video of this. This is the picture showing, but I want to jump to this, and I'll try to get it to play. So at this point, I'm placing at 12 millimeters up the length of the superior oblique. 12 millimeters, large amount of torsion for this patient. Once it's secured at that location, I can imbricate both sides of the tendon. You can pull it with a small one and appreciate that is the insertion. So just temporal to that, I will take a small bite carefully, imbricate a small bite of the sclera with each of the needles of 6 micro. So we have both sides of the vicryl coming down and attaching just temporarily. Adjusting back here is difficult. So the next step of the plication process makes it so much easier is to use what we know about a hemi hangback and securing this up front. So I ask the assistant to get a small hook, and I'll get a small hook to me, and then I will take both of these stitches that I just imbricated here and reattach them up front. Right next to it, I'll place the other one. I like noose adjustable technique. Fibers, that complex pulls temporally, and then it's extended up to its new insertion site. At this spot, I put in, so we have a imbrication back, a plication back here, extending up to a hemi hangback of noose technique. It's fairly close to the lateral rectus muscle temporally. A recession that I might allow. Caliper. This is a 12 millimeter plication. I know this patient has a large degree of torsion. There's no reason to leave a lot on the table. So I am going to imbricate this at 7 millimeters. Why 7? Well, I can give back from 12, I could give back 7, that would leave me 5. If the patient had a funny result from there, you can always cut it. But I know I want an in-torsion effect.
more of a hangback to be communicated, thus less of a plication. There's my fiber, anterior fibers pulled torsionally. Here's my bending hangback, the noose is secured here. It's secured up front with the noose in an adjustable way, easily accessible, and we have it changed.
You see the corneal markings as Dr. Santa described on the cornea. So how is this done for me? I've probably done over 100 of these now for varying amounts of torsion with purely torsional strabismus and or associated with other vertical. And I decided to look back, and I have these two manuscripts that are grouping these two. Some tips along the way. Mark the corneas as been articulated before. Carefully isolate the superior oblique. When you isolate the superior oblique, you need to separate these fibers as far nasal as you can. I use the Barbie, and I put the anterior fibers on two large hooks, and I take the Barbie and push it all the way, the posterior fibers back, and then I get in a forceps, and I pull away all of the posterior fibers, because I try not to affect those. I don't want a Brown syndrome. And then as you saw here, the rest of the case. At the end of the case, double check a Saunders test is what I do. I grab the infratemporal limbus, and I push up and in and make sure that there's not a Brown syndrome. I look back at only the patients that had this procedure and or maybe with a horizontal component, but no associated verticals. And there were 14 of those isolated. This was just accepted to APOS. Because it's being published, I didn't want to give all the details here, but stay tuned. It will be in the Journal of APOS. I'll give you a quick synopsis just about a couple of things. I see them post-op, and I do an adjustment. As was articulated, we expect to have a little overcorrection. For unilaterals, I'll be happy with like 5 degrees of intorsion. Bilaterals, a little bit more. And I adjust these in the treatment room. For those of you that do adjustments, especially with the noose, you understand how successful that can be. So, and again, so there are times where you have vertical strabismus and other factors that you may choose other surgery if there's a meaningful vertical. But for me, I go through now and I can tailor my approach. If I have a patient with 4 degrees of intorsion, I'll generally plicate. I often take off 1 millimeter. Why? Because I reattach it just in front of the superior oblique. So there's always a little bit of an advancement. You can't reattach it where it reattaches. So I often cut back a little bit. And obviously the bigger amounts of torsion, the more I might be cautious and allow my flexibility later. You can adjust it and plicate at 12, but hang it back 5. And let yourself afterwards pull it up, which is easier than getting it to go back. You can. There are ways with Saunders and things get it to relax afterwards. But you can choose unilateral, bilateral approaches and make it very custom for the amount of torsion you have. And so my patients, again, this is coming out, my series from 2 to 24. The 2 was actually a retina patient with very finicky torsional issues, and so that's very minimal. And I look back, typically you can have a very, very tailored approach. Jonathan Holmes said for each amount of advancement, 1 millimeter gets you about 1 degree, and that's what I'm finding. In addition to that, you may get about a degree or a prism diopter or half a prism diopter of vertical effect. Almost always, patients have meaningful torsion. There can be a slight vertical of a diopter. If it's 0, still do this. But if there is a hyper, do the bigger amount of application, or do the application in the eye that's a diopter high or 2 diopters high. If you have a bigger vertical deviation, you're going to be choosing another surgery, whether inferior oblique or superior oblique tuck or something else. But keep in mind, if there is a micro vertical, you do this on that side, because I maybe will see a half a diopter or a diopter of a vertical change. Doesn't seem to affect horizontal deviations. I've done them with like a BMR or other combinations, and I've had a great response. Initially, it's a little bit strong. I get maybe a little bit more than 1 degree per millimeter, but as it relaxes, that's about what I get. And again, Dr. Holmes suggested this with his advancements technique. But why do I like this? I like this because I have a tailored way rather than expecting the Fels variant, a tailored way to correct torsion, and allows me even high degree. I had one patient that 30 degrees of intorsion, and I nailed it. 24 degrees, 18 degrees. To me, it's allowed me the ability to successfully do this in a way that's easy to adjust post-op. And that's what we just talked about here. So it is retrospective. This is a small amount. The second publication that should be coming out soon is this combination with other verticals. What about doing a superior rectus on the same eye that in a patient that has a hyper worsen up gaze and also has a little bit extortion? You recess the superior and bring down the vertical, you might make their torsion worse. And this allows you in the same wound to do a little bit about. There's combinations, you'll see that coming. So just conclusion, this allows for a targeted correction of extortion. I presented this last year in Delhi and was welcome back to talk about it today. And it's just a new technique, a new trick on an old friend, the superior oblique, with old friends in my colleagues here. One other plug, just I have 6 seconds, is I've also enjoyed being at the Mike more, and we have a podcast every 2 weeks. You can go on YouTube and see a variety of subjects that have to do with ophthalmology, and it's been a lot of fun to learn how to be a spokesperson on a variety of areas. So if you're interested in podcasts, you can tune in and do that, and I do thank you to be back with old friends.
Thank you, Eric, for that wonderful talk and sharing those tricks with us. We have a few minutes right now to discuss a few questions. If you have any questions, audience or any co-panelists have any questions?
I have a question.
I have a question.
Can we take, or probably you can go ahead, yeah.
So my question is in 6-nerve palsy to Swati Phulajale. So she said you do Foster's augmentation. When do you decide to do a scleral bite and when you decide not to do a scleral bite? Like Foster's augmentation is when you do a superior rectus or a vertical rectus transposition, you tie the muscles together. Do you then just tie them together or do you always anchor them to the sclera? Do you have any difference of opinion? Because I read some articles in which by Dagi et al. And Mahindra et al., they said that it might produce torsion if you anchor them to the sclera. So I'd like the panel's opinion on that aspect.
I do always, yeah, Swati, go ahead. And then
in DRS, Dr. Saxena said he never anchors to the sclera and he never takes a PFS, but in 6-nerve palsy.
Yeah, 6-nerve palsy, I always suture it to the sclera. I don't do it to the muscle because over time we know that the lateral rectus doesn't have strength and it's going to just spread out and you are going to reduce the efficacy of the transposition procedure. So I would always, suture it to the sclera and never to the muscle. I won't touch the lateral rectus at all because I anyway don't want, because I don't think it's going to be any effect and I don't want to even accidentally reduce or incorporate the vessel of the lateral rectus in my suture because I'm going to probably do a medial rectus, I'm going to do a superior rectus, so I'm doing 2 muscles in one go, so I don't want to even take that small risk of accidentally touching the lateral rectus vessel. And as I said, over time there is a risk that the lateral rectus may actually spread out. So the efficacy is going to be less. So that's why I anchor it to the sclera.
So you just take a bite from the superior rectus and to the sclera?
Yes. The important thing whenever you're doing any transposition procedure is that you need to well dissect the nasal side of the muscle. Otherwise, you're going to have a lot of pull that is there, and that may possibly be responsible for a bit of torsion that may be reported. But extensively dissect whenever you are. Particularly, you must cut the frenulum that is there between the superior rectus and the superior oblique. When you check back, you'll see the superior oblique is kind of bunched up and is getting pulled laterally. That may be, again, another cause for a torsion that you may generate in the post-op period. So you need to check that, and you have to confirm that your superior oblique fibers are now back flush with the sclera and not being pulled nasally with your superior rectus transposition.
Yeah. Just
I think also one more thing we need to remember is ultimately whenever you do a transposition, what that vector force changes is mainly because of the Foster's augmentation, not because of the transposition. The force which gives that vector strength is mainly the Foster. So if you want to do a superior rectus transposition, for example, it has to go closer to the lateral rectus, which is inactive, and probably pass through the sclera. And personally, I do it the same way for Duane syndrome and sixth nerve palsy because of this reason. And as Rohit suggested, you have to really pick up those muscles, not that stimulants. Sometimes in that limited space, people think that this is the muscle and then they may pick up that frenulum or tissue. That may not be. So this is very important, I think, in my opinion.
Just one more question to Dr. Rohit Saxena. In case of DRS, you showed that XT veins with large upshoot in which you did periosteal fixation. So which are the cases you will decide on a periosteal fixation? You could have done a Y-split also because it had a large upshoot. So what are those points in which you...
So it's just a matter of degree. If there is a modest upshoot, I would probably do a large lateral rectus recession or a moderate lateral rectus recession with a Y-split. But like in this case, the retraction was very severe. And particularly if I don't see any significant abduction being present, so I feel there's not so much to lose, I would probably prefer a periosteal fixation. But as I mentioned, a third of them may go into consecutive ESO. So the most important thing to look for is the abduction in the preoperative period.
Any role of looking at the retraction, amount of globe retraction here?
So yes, I mean, that would be the primary reason in which I would decide. So if it's a modest retraction, I would probably stick with just a large recession or a recession with a Y-split. If it's very severe, then I would at least start considering and then take a call of what is the advantage or disadvantage of periosteal fixation.
Okay, thank you.
One catch there is probably if somebody has 4+ or 5+ overshoot with the significant retraction, the primary position deviation is close, maybe 10 or 15, then periosteal fixation will be really too much. They will go into esotropia over a period of time. If it is moderately maybe 25 or 30, I think unless you deactivate the lateral rectus, it's not going to go, even with the Y-split. That's a small catch there in this kind of decision making.
Okay, thank you.
Next, Shubhangi, we can go and then.
Okay. I just wanted to ask Dr. John that the Y-split of superior rectus, how far do you put the splits? As in LR, we do it 20 millimeters apart for DRS.
So basically, how much you cut? That's the question.
How much you
Right.
split it?
The Y split for the third, then you need to go very far posteriorly, as far as you can get. For the Y split for the super rectus, for instance, or for the medial where we work, we take 12 to 14 millimeter split. And you have to be sure, and one thing I want to share with you, probably you know this already, but when you do the split, if you start from the behind, so we look at the muscle and put the small suture hook behind through the muscle and go forward to the insertion. So you have to, so it's not splitting up, so you only have a very thin part in the part. Small, yeah, we use a small hook, goes through, and it usually doesn't bleed that much. But 40 millimeters is fine. If you only split 10, I've tried that as well, it will be stretched out so it's too tight, so you need to split a little bit further behind. Well, yeah, I think if you split it 12 to 14, it will not tighten up. Then you will actually have no deviation effect in primary, but only in the gaze of direction. But if you have the case I showed you, there was a deviation in primary as well. So we combined a recession and a Y split. So you can do both. I think there are many ways to do this, but we always put adjustables in. So if we're not happy with the results.
I think one last question we can take, lady behind. Yeah.
My question, both with the lateral rectus nerve palsy and third nerve palsy, how much time do we exactly wait before we start to make a decision for taking up the surgery?
Yeah, ideally, I think you should wait at least for 6 months of stable deviation. So if it's still, in improving stage or in resolving stage, so you have to wait till it becomes stable for almost 6 months and then decide on surgery.
Okay, and another question related to this is, in the cases of systemic associations like diabetes, most of the times we get self recoveries better when we do not have etiology. But is it possible that even after a noted no deviation, as we see, patients still keep on complaining of mild diplopia?
If you look carefully, you might get some deviation in lateral gaze, in that particular gaze. There may be no deviation in the primary gaze, but I'm sure that on the side of the affected side, you may still have some small deviation, for which that again depends on how much is the amount of diplopia.
Okay, I think we need to stop here, unfortunately, because of the time factor. We will have to move on. I would like to really thank all the speakers for their talk and sticking to the time. And we will have a picture together. And when you are taking the picture, we will call the other moderators to come onto the stage. Thank you very much.